Assalamu alaikum and good evening to you all. Welcome to the master class on OSPE for MBBS final year student episode 2, organized by SCP Bangladesh chapter and supported by Bangladesh Society of Medicine. It is a program which is designed for the medicine OSPE of final professional MBBS examination. On the last episode, Professor Khan Abul Kalam Ahmed sir took a class on X-ray, predominantly chest X-ray. If you missed that historic class, to visit our YouTube channel to find it. Today there will be another class on X-ray by someone who is considered a genius in the field of medicine. Yes, you guessed it right. It's none other than Professor Sujat Pal sir. Sir is the professor and head of the Department of Medicine, Chittagong Medical College. Today's program will be chaired by one of the best physicians in the whole wide world, our very own former governor of SCP Bangladesh chapter, Professor Quazi Tarikul Islam sir. Sir was also a former president of Bangladesh Society of Medicine. As his chief guest, we have another renowned professor of medicine, Professor Muhammad Amir Hossain sir. He is the principal and professor of medicine, Chattogram International Medical College. As a moderator with us, we have a person who is young, talented, and good-looking at the same time. Dr. M.S. Arefin Patwari sir. He is the Associate Professor of Medicine, Dhaka Medical College, and he is also the Member Secretary of SCP Bangladesh chapter. During this live session, you can ask topic-related questions on the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand over the session to Arefin Patwari sir. Arefin Patwari sir.
Thank you, Dr. Prince. Good evening, my dear respected teachers and all the students from different medical college. I would like to invite you all to the master class on OSPE. And basically, this program is solely dedicated for the final year MBBS examinee of this year. And this is basically a dream project of a person. And he loves to work. He works for the students. He works for the teachers. He works for the benefit of the arena of internal medicine. And he is none other than Professor H.M. Nazmul Hasan. I must give thanks to him for everything that we are enjoying from the SCP Bangladesh chapter. And this program has been organized by SCP Bangladesh chapter in collaboration with the Bangladesh Society of Medicine. And Dr. Prince has already mentioned the our name of our chairperson, who is the legendary professor and living legend of internal medicine, Professor Tarikul Islam sir is with us, and we have got as a chief guest Professor Dr. Muhammad Amir Hossain sir, who is the principal of Chattogram International Medical College. And our students are very lucky today because they will hear from a renowned professor of medicine, Professor Sujat Pal sir, who is currently working as the head of the Department of Medicine, Chattogram Medical College. Now, I am requesting Professor Sujat Pal sir to start his session. Sir.
Thank you, Patwari, for your introduction for me, and thanks to the Prince also. Thanks to the SCP Bangladesh chapter for organizing such a wonderful event, and I must show gratitude and respect to the Professor Nazmul sir and Professor Tarikul Islam sir who are with us. Now, the thing is that X-ray Part-2 means the X-ray of other system other than cardiovascular system actually. In fifth year classes, actually we usually concentrate in the cardiovascular and respiratory system. And other than cardiovascular and respiratory system, there are few X-rays that we have to deal with. And the first and foremost, which one is most responsible for the fifth year student is this X-ray. And this X-ray is usually produced in our OSPE section. Here you can say what is the common pathology, what is the positive findings, radiological findings. and what is the likely diagnosis, and we can ask, write down the clinical sign, 4 clinical signs we look for, and we can ask one investigation to confirm the diagnosis. Very simple question actually, and there are 4 treatment options. And the thing is that these types of extras should have to be known to the students actually. It's very common, and this disease is very common in our country, especially in the southeast portion of the region of Bangladesh. Along with Myanmar, there is included E disease, is the most common. Along with there are thalassemia and other hemolytic anemia, hemolytic is very common in our country. So one must be popular with, student must be popular with these types of extra. Another thing is that I'll show only the very important X-ray, and there are so many X-ray related to other system. We will not go details about this. So what are the findings here? We are seeing that there are the trabeculae. This is the outer cortex, this is the inner cortex. Inner cortex is slightly thickened, but outer cortex is thinning of the cortex. The trabeculae is more thickened, producing hair on end appearance. This is the common findings of hereditary hemolytic anemia. If we answer the questions which have been written here, these types of question may be of another type, and I am requesting all the students to go through the hereditary hemolytic anemia to answer the questions of all the questions or all the related questions about this. If we think about what are the positive findings, we can say that widening of the diffuse space. This is the widening of the diffuse space. The outer is the inner, the widening of the diffuse space. Then thinning of the outer table. This is the thinning of the outer table. What I have found, and inner table is a bit thick, but the thinning of the outer table. Then thickening of the portioning of the trabeculae with hair on end appearance. This is called hair on appearance. If you look closely, this is called hair on end appearance. It's due to the thickening of the trabeculae. And all of you know the likely diagnosis is hereditary hemolytic anemia, not congenital hemolytic anemia. This is a hereditary hemolytic anemia. Then we can write down the 4 clinical signs we will look for. 4 clinical anemia, jaundice, splenomegaly, and fasces. There is a prominence of smaller predominance, frontal predominance. Like this, there are many other predominant findings. And there are triad of hemolytic anemia. Anemia, jaundice, and splenomegaly is called triad of hemolytic anemia. And one important question we have to know that the one investigation to confirm the diagnosis is the hemoglobin electrophoresis. Very important. Hemoglobin electrophoresis will give us clue that what types of anemia it is. Is it hemoglobin E disease? Is it thalassemia major? Is it thalassemia minor? In hemoglobin E disease, hemoglobin E and in every aspects, hemoglobin electrophoresis will give you the clue. If there is predominance of hemoglobin F, it is thalassemia major. If predominance of hemoglobin A2, which is the thalassemia minor, like this, we can go for diagnosing by hemoglobin electrophoresis. There are many other questions that what other test, what other radiological investigation we can do to confirm this. The answer is the X-ray hand and X-ray chest. In X-ray chest, there are ribs will be thinning of the all ribs and widening of the ribs, and all the hands joints, bones, all the bones of the hands will be widened, and there will be thinning, and trabeculae will be thickening of the trabeculae. These are the common X-ray of the hands, X of the chest can be done in this case. Another one question can be asked by the frontal boson, prominence of the maxilla, and there is short stature, retardation of growth, etc. You can go through the all questions related to hereditary hemolytic anemia. If we do the chest X-ray, we can find like this: ribs are widened, along with the clavicle maybe widened, and thinning of the cortex in the clavicle. Scapula, if seen, scapula also widened and thinning the scapula, and there may be cardiomegaly because anemic heart failure or tendency to provide oxygen to the or attempt to supply oxygen to the other organ system, heart will be enlarged, or it may be anemic heart failure may lead to cardiomegaly or cardiomyopathy like this. Another thing is the X-ray of the hands. There will be thinning of the cortex and widening and thinning of the cortex, and there will be trabecular will be thickened, like the hair and the penis here. There will be thinning of the cortex, widening, and of the bones also. These are all about hereditary hemolytic anemia. Another thing is that what a peripheral blood film, what can you see? Is a common question. You can be asked. In the peripheral blood film, what are the findings? We can see. If we see the microcytic hypochromic anemia, what are the differential diagnoses related to this slide? We can say hemolytic anemia, iron deficiency anemia, sideroblastic anemia, anemia of chronic disease. And what in peripheral blood, what can we see? We can see some target cells, anisophagocytosis and reticulocytes, or polychromatic cells. In how polychromatic cells can be well defined by answer is that the reticulocyte count. You can see other different strain you have to do, and we can find reticulocytes. When reticulocyte count, the quality amount of reticulocytes gives us a clue that this is kind of major or minor or very severe or like this. You can see these are all about hereditary hemolytic anemia. And I am requesting all the students, those are listening to me, that you please go through the hereditary hemolytic anemia. It's very common in our country, very, and you have to know all about hereditary hemolytic anemia, which have been written in the textbook. Now, next, if we provide you these types of X-ray skull, where there is a punched out lesion and lytic lesion. This is called lytic lesion actually. And why is lytic lesion? And this gives you the one is lytic and as a blastic. The blastic is more opaque, the blastic, and lytic not opaque. There is some rarefaction of the or punched out lesion of different size and shape along the all scalp. So if I say that the further mention the radiology findings, you will say that there is a punched out rarefaction or punched out lesions of variable size and shape occupying the all area of the scalp. Most likely diagnosis is multiple myeloma. And what is the differential diagnosis? The most common questions. The differential diagnosis of this X-ray is 2. For fifth year students, 2 actually. One is secondaries, number 2 hyperparathyroidism. For the fifth year students, and for other there are other things, diffuse osteoporosis, leukemia, lymphoma, like this. But for the fifth year students, if they tell that the 2 common differential diagnoses, one is secondaries and another is hyperparathyroidism, will be helpful. And mention 4 other investigation for this diagnosis is bone marrow examination must. If you think about multiple myeloma, we have to do bone marrow examination and serum protein electrophoresis or urinary protein electrophoresis, Benjone's protein, serum calcium, etc. And serum creatinine also do. But 3 investigation for the diagnosis of multiple myeloma, we have to do 3 investigations. One is X-ray skull, another is bone marrow examination, another is protein electrophoresis. If any of the 2 is present, we can say that the patient has been suffering from multiple myeloma. But multiple myeloma patients can be presented in the old age in elderly patient with backache, actually backache, and there will be the anemia and their signs of CKD or creatinine level will be high. If such types of patients, elderly patients with backache, with creatinine level high and anemic, and there will be bone tenderness, maybe we can think of multiple myeloma. Actually, you have to think about it. And there may be another thing is the unexplained anemia, maybe the presenting features of this types of multiple myeloma. These types of disease, this multiple myeloma is also very common in our country. And another few questions you can be asked for, or as in OSPE they can be given for the mode of moderator treatment, or the principles of treatment. You can go through the books for the management purpose or modalities of management purpose. Next, This X-ray can be given in your OSPE because we have to deal with acute abdomen. In acute abdomen, the patient has come to you, and you have done a one plain X-ray abdomen. You will find there is some calcification along the anatomical position of the pancreas. If this happens, we should have to think that there is a case of pancreatic calcification. Another thing is that if you go through the maculates or other things in acute abdomens or pain abdomen you have to encounter with these types of pain abdomen. If it is so, you have to think whether it is pancreatic calcification, whether it is duodenal ulcer, whether it is acute cholecystitis or acute pancreatitis, or even another differential is renal colics also may comes with pancreatic may comes with acute abdomen. Besides this, there are two other diseases may present with is a common phenomenon actually. I should say, inferior MI, inferior myocardial infarctions may present with acute abdomen. You have to think for it, which is elderly, smokers, diabetic, hypertensive, inferior MI may present with acute abdomen. We have found many cases. You can think for it. Another thing, in acute abdomen, there are some diabetic ketosis may come with acute abdomen. So, in a patient of acute abdomen or pain abdomen, if and actually in pancreatic calcification, it may be chronic pain, but these types of patients may come with acute abdomen. Recurrent acute pancreatitis may happen in these types of pancreatic calcification. So we can ask that mention 4 presenting features you can expect, like this acute abdominal pain, and there's pancreatic calcification, there's sensory malabsorption, weight loss, like this. Mention 3 other important investigation to establish the diagnosis you can ask for. There's different types of questions, but the thing is that this is a plain X-ray abdomen, where if we are finding some pancreatic calcifications of different size and shape, which is located along the anatomical position of the pancreas. That's all. And then you can give some answer to that questions. Recurrent abdominal pain, malabsorption, DM, weight loss, like this. And for the confirmation, we can do for the confirmation or for additive. For addition, we can do ultrasonography. CT scan is a very much important investigation in here. Then pancreatic function test, secretin stimulation test, and you can do RBS for to see the diabetes. As islets or Langerhans will be destroyed, there will be formation of diabetes. There will be the occurrence of diabetes here. And there are some many pain NSAIDs you can prescribe. Actually, this pain is more very critical, very crucial, and no NSAIDs, no opioids or gabapentin can reduce the pain here. But you have to try, and you can go for surgery or celiac clusters neurolysis, like this. And endoscopic removal of stone actually in pancreatic calcification is very tough, because there are multiple calcification or calcified shadow. Is very tough to remove all the stones here. You have to think for it. Related to pain abdomen, we can give one OSPE here. Another, the patient comes with acute abdomen. Actually, what I am telling, any surgical cause, perforation or acute appendicitis or cholecystitis, first come to the internist or in medicine department. The patient comes with pain abdomen. You have to think whether it is perforation, whether it is peptic ulcer disease, acute absorption of peptic ulcer disease, or whether it is acute appendicitis or renal colic. Like this, you have to differentiate here. For this reason, we can do one X-ray. This is a very popular X-ray. Pain X-ray abdomen in erect posture, including both dome of diaphragm. This is a very popular X-ray you have to do in a patient of acute abdomen who has comes with acute abdomen and vomiting, just abdominal distension. We can do this X-ray, and we can ask for what are the positive findings. You will see that there are presenting shadow on both sides of the diaphragm. Out of the radiological diagnosis, we can say that there is a perforation of the hollow viscus. Write down the 2 most common underlying cause. Peptic ulcer disease perforation, very common in our country, and typhoid ulcer perforation is also common in our country. It's a medical problem. Or tuberculous ulcer perforation is common in the medical problem. For surgical problem, road traffic accidents or stab injury may happen. For the single physical signs, can support this diagnosis? Answer is obliteration of the liver dullness. This is the most, and this is the most clinical test we can do to exclude perforation from other diseases. And in here is there will be the boat-like rigidity, which may happen in other cases like pancreatitis. But from here, to differentiate from peritonitis from other causes, we have to do one test, obliteration of the liver dullness, and mention 5 points regarding management, the surgical management. Actually, you have to refer this patient to the surgery ward for proper care. The thing is that this is the plain X-ray abdomen, erect posture, including both dome of diaphragm, which are been showing the crescentic air shadow on both sides of the diaphragm, and there will be abdominal extension on clinical examination. What I have told it, these types of X-rays can be given in the OSPE. And this is a surgical management. And another thing, all things has been discussed by me. Okay. This is another question, another plain X-ray abdomen and erect posture, of course, including both dome of diaphragm. And this plain X-ray abdomen, you will see that for the residual findings, there are the multiple air fluid level, multiple cavity or air fluid level I am seeing. If this air fluid level is more than 3 or 4, we can go for acute intestinal obstruction. If there are multiple shadow, but there is no air fluid level, or it is less than 3 or 4, we can go for subacute intestinal obstruction. And in diagnosis, acute intestinal obstruction or subacute intestinal, there are surgical cause, there are medical cause. In medical cause, it's usually constipation in the elderly, or hypothyroidism, or tuberculosis, maybe in cases intestinal tuberculosis or colonic growth is maybe surgical, but comes to the internist, or interception in the children, you can do, or in very young child. If it is young child, we can go for obliteration of the Hirschsprung's disease, maybe the one differential diagnosis. Any obstruction, number one. Number two, some medical causes like constipation and hypothyroidism. Elderly patient, bedridden patients may come with these types of question. Or paralytic ileus is another cause actually, may come with these types of picture, where we have seen that there are multiple shadow with air fluid level. Yeah, this is air fluid level, this is air fluid level. If it is more than 3 or 4, we will go for acute intestinal obstruction. If it is less than 3 or 4, we can go for subacute intestinal obstruction. And mention 4 symptoms and how to treat the patient. Actually, the treatment of this X-ray, treatment of this patient with this X-ray is actually surgical. If there is no medical treatment as our infection of fecal matter, we can go for medical management. Otherwise, we can go for surgical management whether there is any treatable cause for obstruction. But in some cases, there will be no treatable. Usually, metastasis to all the hollow viscous, they will not treatable. We have to think for it to search for what other investigation we can do, like acute pancreatic resection. What other we can do on CT scan, like this another, and these patients may be the candidates for surgical management. Yes, another abdominal pain, vomiting, constipation, abdominal distension. These are the other features we can deal with. And their air fluid level, and surgical management means nothing but mouth, IV fluid, IV nutrition, IV antibiotics, in protein pump inhibitor, and painkiller in the form of, if there's a distension, you can give NG-tube. You can introduce NG-tube for suctions. This is the surgical management of this patient. This is the X-ray hands. Is very common in our country actually, and in our Chittagong Medical College we have these types of X-ray. In our we can give it to the OSPE or in the table to explore what are the diagnosis or what the radiological diagnosis here, and what are the positive findings. Actually, positive findings here: proximal interphalangeal metacarpophalangeal joints. Here the findings, and proximal interphalangeal joints. Here is the. And this is also positive findings. Right at the clinical diagnostic criteria actually. Radiologically, these are the disorganized or distorted or erode metacarpophalangeal joints and proximal interphalangeal joints, and there is a like the swan neck or Bartonian deformity or jet deformity or ulnar deviations. There may be ulnar deviations, and you have to diagnose this as rheumatoid arthritis. We can ask one question: why not it is necessarily? You will tell that there is a destruction of the metacarpophalangeals or proximal interphalangeals will not be occurring systemic lupus erythematosus, and distal interphalangeal joints will be involved in case of psoriatic arthritis, but proximal interphalangeal joints, metacarpophalangeal joints and proximal interphalangeal joints along with wrist joint, there is change in the wrist joint, will be present in case of rheumatoid arthritis hand. Therefore, prognostic factor. It is there are several questions or different types of questions we can ask, suggest for investigation for this patient, and write down the complication that may cause sudden death of the patient. And write down the clinical diagnostic criteria. You can say that there are four diagnostic criteria: bilateral symmetrical joint pain, and small joints of the hands, morning stiffness, like this you can tell. But in 2010 SCI or EULAR criteria, you'll see that there are some 11 or more than 6 points. If there is more than 6 points, you can do the diagnosis of rheumatoid arthritis. But these types of questions may not be asked to you. We can give only the X-ray, and if in X-ray you'll see the changes in the metacarpophalangeal joints and proximal interphalangeal joints will be happening. And mention 4 prognostic factor like this: early development of rheumatoid nodules, extra-articular manifestation, functional impaired with female sex. These are the things. And for the confirmation of for the confirmation, we do the RA test and anti-CCP antibody for the confirmation. We can do this test. And another thing I have to discuss is the bottleneck deformity and swan neck deformity, ulnar deviation, and subluxation, or jet-like deformity of the thumb. This can be asked. And extra-articular manifestation you can read in your books. There are some extra-articular manifestations like Pelti's syndrome, and Sjogren's syndrome, hepatosplenomegaly, like this lymphadenopathy, or the extra-articular manifestation. If there is extra-articular manifestation, you see, is a bad prognostic factor for the life, and if it is female sex, is a bad prognostic factor. There is a common occurrence of atlantaxial subluxation, which may cause a compression of the spinal cord, may cause death of the patient. Another thing is that the mode of treatment, methotrexate is the very common drugs we can use in the rheumatoid arthritis. And actually, in the 5th year students, we expect that they know something about rheumatoid arthritis and SLA. And we have often put questions in the written question, and in the OSPE, these types of hand can be provided to assess your knowledge about rheumatic disease. This X-ray, actually, this is a dorsolumbar spine, extra of the dorsolumbar spine. Actually, this is the dorsal spine, and there are a few lumbar spine. Here we are showing that there are some structural deformities or disorganized or erosions of the intervertebral disc, along with compression of the one vertebra. This step, and another some paravertebral. This is a plain extra. I'll show it in another slide. Here also there will be the this is intervertebral disc. There is a shortening or thinning of the intervertebral disc. This is a clear-cut intervertebral disc, but there is shortening or thinning of the intervertebral disc, or disorganized or erosions of the vertebral ends. These types of pictures will lead to diagnosis of horse disease. Actually, these types of disease is common in our country. You see, this is a sharply demarcated intervertebral disc along with vertebral border, but here this is disorganized. We have to, this is the X-ray dorsolumbar spine AP view, not PA view. This is dorsolumbar spine AP view. For the clear-cut demarcation of this, we can do another X-ray a lateral view, and or for more definition of this pathological changes or radiological changes, we can do another MRI of the spine. Here we can easily define that this is a clear-cut vertebra interval, but here is vertebral change is there, all vertebrae affected. There is vertebral erosions and disorganized intervertebral disc, and there are interesting things. There are some paravertebral soft tissue shadow. It could be happening in the cervical region to the dorsal region, but in the lumbar region there is less chance. Dorsal and cervical, mainly dorsal, is the common sites of horse disease. If these types of findings we can find, and for the more accurate delineation of this pathological or radiological change, we will do. Your answer will be, we will do, sir, MRI of the dorsal lumbar spine. Then, what should be the next procedure to establish the diagnosis? Mention 3 neurological factors. These are very important questions we can ask, and we will find these types of patients very commonly in our common practice. Actually, in 5th year, we will give the diseases which are very common in our wards and common practice. And this is the this is the most important question. Is they mention 3 important neurological features you may expect in this patient. What are the things? Spastic paraplegia, bilateral extensor, and spasticity. Sensory involvement. There is a sensory level. There should be a sensory level, and bowel and bladder involvement. For the confirmation, you can do CT guided FNAC. And in the Pors disease, what are the other clinically, what are the other clinical signs we could find? You can tell that we may find there are gibbous in the dorsal lumbar space, or gibbous present in the dorsal column of the patient, and the patient may cause backache, may complain of backache, and gradual weakening of the all of the both lower limbs, and there is bladder and bladder retention of the urinary bladder. And for the radiological changes, I have told it earlier. Early received changes located in the margin of the vertebral body, destruction and erosion of the intervertebral disc, and paravertebral soft tissue shadow. I have told it earlier. For better understanding, I am telling the paravertebral soft tissue shadow, which I have shown. This is the paravertebral shadow. This paravertebral shadow may have sleep like this here, producing the psoas abscess. You can you can know all these things also. And these types of X-ray, either plain X-ray, where we will find the destruction and erosion of the vertebral and intervertebral disc deformation, disorganized intervertebral disc, along with in MRI, we will find these types of findings, and we will diagnose this as a Pors disease. What is the treatment of Pors disease? Is the anti-TB drug for how many days? At least 1.5 to 2 years. In Bangkok, one of my patients received 2 years treatment for Pors disease. In many of the books, it is 1.5 years, but 2 years may be extended in case of Pors disease. And along with support of the vertebra with lumbar corset, and after starting of anti-TB, we will go for neurosurgery, whether there is if there is any obstruction to the or produced radiculopathy, or bladder obstruction, or retention of the bladder, or any neurological changes, we should go for neurosurgery department. These are other findings, eradication of the vertebral and pairs. These are the common findings we can find in case of Pors disease. Interestingly, is that this plain X-ray abdomen, X-ray radiological dorsal lumbar spine, showing the light lesion in the vertebra, you see, but intervertebral disease is more or less intact. So it should not be Pors disease. It will be secondaries to the vertebra, like this, secondaries to the vertebra. This X-ray showing in details, intervertebral disease is more or less intact, but there is osteolytic lesion in the vertebra. These types of happening will be present in case of secondaries of the vertebra, not in the Pors disease. And we can ask from where it comes. These types of metastasis comes from those from carcinoma which are hematological transmitted. Why the hematological transmission is there, like thyroid, breast, cystoma, and endometrial carcinoma, prostatic carcinoma, lung cancer, very small cell carcinoma. This may metastasize to the vertebra, producing these types of erosions, keeping intact intervertebral disc and diagnosis secondaries to the vertebra. And you see, if you do MRI of this intervertebral disc more or less intact, but the vertebra is destroyed here. Here, I am showing another slide, the hip osteoarthritis. It's important. This is the normal hip actually. The normal hip. The joint space is normal, but here is no joint space. It's called bone on bone. There is no intervening space. This is called bone on bone. Another is sclerosis of the margin of the head of the femur. Sclerosis. Another, there's some cyst will be found in the femoral head, and ultimately there will be disorganized this hip bone. If such types of findings happen, we can say that this is osteoarthritis of the hip. And osteoarthritis, it is very common in our country, especially osteoarthritis of the knee, where you can see osteophytes. Osteophytes means the new bone formation, and there is reduced joint space, bone on bone, and there is sclerosis is there, and in some cases we can find some cyst here. These four findings will lead to diagnosis of osteoarthritis, and in the obese patient, in the elderly, is very common, and then those who are using the hip joint after the age of 40, manual laborer and sports, those who are involved in sports like this, manual laborer, they have been suffering from osteoarthritis. The hip and knee is in very frequent. They are suffering from osteoarthritis very frequently. So we have to go for we have to learn or know something about the osteoarthritis. The common risk factor for osteoarthritis. How can it actually these types of osteoarthritis may not be that you can give some painkiller, but physical medicine specialist can do something better. And in some cases, if it is more disorganized, you can go for surgery, total hip and knee replacement or arthroplasty you can do. I can say to all my students that you should go through the osteoarthritis of the hip and knee, which is very common in our country. Another X-ray is common, but not so common like rheumatoid arthritis and osteoarthritis or Pors disease. We can find these types of X-ray also. We can say what they mentioned, three abnormalities is here. This is syndesmophytes. Abnormalities in the here. This is the calcification and sclerosis of the anterior spinal ligaments. And findings is here, SI joints is sclerosed, disorganized, or distracted, or fusion of the sacroiliac joint. These findings is more common in case of one diagnosis known as ankylosing spondylitis. This is common in our country. And mention first management for this, and the drugs can be used. These are common. There are some questions you can see, but these types of another findings may happen here. The patient may comes with loss of lumbar lordosis and question mark kyphosis, and if these patients in these patients you can do Schubert test, modified Schubert. You have learned it in dermatology clinic, and what is modified Schubert test. These steps and this back pain. What is the differential diagnosis of this back pain? What are the red flag sign of back pain? You can learn. You can learn these things from your book. What is the red flag sign of bone pain here? If it is there is back pain, what is the red flag sign? What is the modified Schubert test? And loss of lumbar lordosis, question marks. And another thing is that occiput to wall distance. Another test we can do. The patient's occiput to wall distance will be will be gradually lengthened in case of ankylosing spondylitis, and as it is not so common, we'll give it rarely, but for the understanding, I have shown this slide also. Now I can go for it is also a surgeon involvement, and this I have been discussed. I can discuss what is syndesmophytes is actually calcification and heterotopic ossification of the interspinal ligament. It's called syndesmophyte. If it is this syndesmophyte precision laterally, and in the middle there is calcification of the anterior spinal ligament. And another thing is I have told it earlier, the squaring of the vertebra, loss of lumbar lordosis, will give you clue to the diagnosis of ankylosing spondylitis. And there are many treatment options, including biologics. I have told it earlier, when we have to deal with acute abdomen or pain abdomen, we have to think about renal colic or renal stones as a differential diagnosis of acute pancreatitis, acute cholestasis, or peptic. In renal stenosis, if you find such types of, we have done one plain X-ray abdomen or plain X-ray KOB, we have done it. The person is complaining hematuria or pain abdomen. I have seen one or two cases in that the patient complains of vomit, along with line to groin pain. In the patient, if there is a stone in the kidney level, the patient may complain of upper abdominal pain or pain around the umbilicus. So if such types of radiological changes, some opacity you find in the line of ureter, you can say the ureteric colic. Or if you see the such types of Stackhorn calculus like this, or if you find these types of, you can go for diagnosis of renal calculi. And if there is renal calculi in the internist, as internist, you have to do nothing. You can refer this patient to the urologist or endoscopic ward, and for the surgical management actually. And the patients may come with loin pain, hematuria, recurrent and renal impairment actually. But the patients may come with pain abdomen if the stone is high. The position of the stone is a bit higher. The patient may come with, and in the MacLeod you will see the cause of pain abdomen. They elicited that the peptic ulcer disease, acute pancreatitis, acute cholestasis. Along with this, there is a renal colic or renal calculi. Mr. Chairman, sir, and respected chief guest and others, this is the end of my discussion about the X-ray part 2, and I am ready to answer the questions if anybody asks to it. Thank you, sir. Thank you, Moderator Patwari and Prince, for your moderation and giving me the chance. And thanks to the SCP Governor, sir, for considering me as a person to have a capacity to tell something in front of the August gathering. Thank you very much. Thank you. Thank you, Patwari.
Thank you so much, sir, for your excellent presentation. Now it's time for the question and answer session. These are the questions that you ask in the comment section during the live session. So without doing any further delay, I would like to request Dr. Arefin Patwari, sir, to start the question and answer session. Dr. Arefin Patwari, sir.
I think our students will be benefited from your speech, and I think not only the final year MBBS examinee will be benefited from your lecture. I think all the postgraduate students will be benefited today from your lecture. Now we have got few questions from our participants. Shamanta from Borishal Medical College, she wanted to know how can we differentiate the pancreatic calcification from the nephrocal Sinuses radiologically?
Yes, this is a very important question, Samantha. In pancreatic calcification or calcification due to actually gallstone is not radiopaque, but in some cases gallstone also radiopaque. In pancreatic calcification, you have to do, for differentiating these two, we have to do one X-ray lateral view. If the stone is situated posterior to the vertebra, then it is renal stone. If it is anterior to the vertebra, it is either pancreatic calcification or gallstone.
Thank you, sir, for your nice answer. And we have got another question from Fatima Khatun from the Sar Solimullah Medical College. She wanted to know, is it possible to differentiate different osteolytic lesion from the X-ray, like multiple myeloma, secondaries, or hyperparathyroidism?
Yes, actually, I have forgotten to tell you this. In differential diagnosis of past out lesion of the extra skull, we have to consider three things. One is multiple myeloma, another is secondaries, another is hyperparathyroidism. In hyperparathyroidism, this passed out lesion of variable sizes is a bit small. It's like pepper pot appearance. And considering these things, along with other clinical signs, you have to differentiate whether they has been suffering from secondaries, multiple myeloma, or hyperparathyroidism. I have told it for that establishment of the multiple myeloma, we have three criteria. One is bone marrow, this X-ray, and another is protein electrophoresis. In secondaries, we have to search for another thing. In hyperparathyroidism, we have to search for the primary cause, secondary cause, tertiary cause, like this.
Thank you, sir. From Shohid Sorardi Medical College, Sadia Kobir, she wanted to know in situs inversus, where we will get the funding gas in the right side. Then how will you diagnose a case of perforation hollow viscous in case of situs inversus?
Actually, in perforation of the hollow viscous, there may be unilateral cassillary shadow, there may be bilateral cassillary shadow. In dextrocardia, first you have to know what is the dextrocardia or not by marking. There will be marking in the chest X-ray, the right or left, and it is very usual practice that marking of the X-ray is important. If right marking, if there is a funding gas in the right marking, then apex beat is shifted to apex beat is located towards the right, we can go for dextrocardia. But in situs inversus, if there is apex of the heart is located toward the right, there is marking at the right side, we can go for situs inversus. But if there is no situs inversus, and another thing is that we can find two shadow there. One is for funding gas, another is for cassillary shadow for the pneumoperitoneum. Two shadow. One is for funding gas, and there is a opaque cassillary shadow, then pneumoperitoneum. And in some cases, when it is advanced on, there will on both sides we'll find the pneumoperitoneum. If we find it on the both sides, there will be no confusion. But if you say finding the right side or one side, there will be maybe confusion. But if this confusion can be managed by diagnosing dextrocardia. And there are other evidence of clinical evidence of pneumoperitoneum, like peritonitis and obliteration of the liver damage. Another thing, this things you should have to consider here.
Thank you, sir, for your answer. We have had our last question for today. That is Farjana Rahman from Dhaka Medical College. She wanted to know, in case of suspected pulse disease, where there is a paravertebral shadow and other findings, and the patient has presented with paraplegia. So, but the diagnosis is still due. In that case, which treatment we'll choose first, whether the decompressive surgery or waiting for diagnosis and starting the anti-TB drug?
Thank you very much, Samantha. Farjana
Rahman.
Very important questions. And another interesting is that Patwari, all students who have questioned to you is all are female actually. I have seen all female students. Where is male student? Okay, this is just Farjana is a very important questions in the management of pulses, whether they are anti-TB fast or decompression fast. My thinking is that we have to start anti-TB and anti-TB without steroid. I think our chairperson will comment on this, without steroid, because we want fibrosis. And there is evidence of radiculopathy or compression of the nerve. Actually, we should go for surgery for decompensation. And these two things we have to do simultaneously, keeping or watching that there is no more destruction of the nerve due to the bending of the destruction of the vertebra. We have to think of. I have one patient now in my in one clinic. We have given anti-TB drug without steroid, and we are watching this, and we have given lumbar corset. No wash. She should not go to washroom. Everything in the bag, and wait for 15 days to 1 month. If there is fibrosis or if there is just stiffening of the vertebra, and if there is persistence of radiculopathy or nerve compression, we should consult neurosurgeon. I think our Professor Tarikul will give comment on this also. Thank you all who have questions. Any questions, Patwari?
Thank you, sir, for your excellent speech and also the excellent answer. I think all the students will be benefited from your speech. Now, we are interested to hear a few words from you, sir, Professor Sujat Pal. What is your feelings after giving the speech in a virtual media to all our fifth year, final year MBBS examining?
Okay. Actually, I am very much excited, and like others, I am very much well acquainted. I feel very much encouraged or privileged when anyone request me to say something. I am very much privileged and encouraged actually. And another thing is that when I have got message from our sir that you have to tell something about X-ray, I have written many things. By this, I have read many things. By this reading, my concept has been cleared in many ways. And this is one thing. The another thing is that I am also excited that I am now in touch in this moment. I am now in touch with the many critical students of the whole of the Bangladesh. It's a rare opportunity to be in Patwari. Actually, it's a rare opportunity, and thanks to the organizer, Professor Nazmullah sir and others who are Arefin, who have given me the chance to do these things, to establish a communication with all the 50 students of Bangladesh. I am very much lucky actually. Thank you very much. Thanks you all.
Thank you, sir. Now, I would like to request our chairperson, Professor Qazi Tarikul Islam sir, who is a legendary professor and the living legend of internal medicine in Bangladesh and also in abroad. We will be delighted to hear some few words from you, sir. And I would like to request you to conclude the session also.
Thank you. Amadir, chief guest is not available.
Yes, sir.
Is that okay?
Yes, sir.
First of all, I must congratulate Professor Sujat Pal for very excellent deliberation, but for two reasons. He made the things actually very appropriate for the student. What could be the possible question and how will you answer? My observation is one, that he discussed it, but the question may not be so big, because you know, for the present situation, it is only 5 minutes, 5 marks. So if it is 5 minutes, the moderator will set the question what he wants. If it is 10 minutes but 5 marks, also we will accommodate the answer question layout and the answer in such a way that the student can pick up very quickly and answer also very appropriately. As he has shown the whole issue to the student, so it is not that exactly in this way the question will come. It can be in a permutation combination, the emphasis or weightage or the mark can be shifted from diagnosis, investigation, then differentials, management part. It depends on who is preparing and what the teacher is asking for. So I'm so happy that he has touched all these types of issues And it is particularly our X-ray session 1 I witnessed. Professor Khanabul Kalam Azad, he also mentioned detailed about this, and no doubt that only from chest or cardiovascular and respiratory the X-ray will come. No, this can come from other part. Today, if you think that this is little bit hard or difficult, but when our students are asking question, I'm really amazed for one issue, that we were thinking that maybe it will be hard for them, but it is not, because one question was very interesting. If it is a Part-1, what to do? That means the students are going through this. Professor Sujat very clearly told, you see, this is a case of cord compression. You have to rescue the patient at this moment. So if at all clinically you suspect Mantoux test and biopsy from there, it takes 5 days time or 1 week time, you clinically, you can start treatment to save the life of the patient, because once it is permanently damaged, the cord, whole life the patient will be incapacitated. So it is better to start. It is very common in our country. It is the differential of POTS is also POTS. Very rarely it comes as a secondary deposition or primary malignancy of that area. So I think Sujat has very excellently explained to that. Another issue I must tell, one very intelligent question was, if there is situs inversus. My dear student, I must congratulate you for this question. This is an intelligent query rather. If the stomach is on the right side, mind it that above the stomach, below the diaphragm, there will be a crescentic border. So there will be 2 shadows, one above the diaphragm and below diaphragm is the fundic gash. And fundic gash is a good amount, and below that there is a line, that means the food content of the stomach. So it is very easily can be differentiated from the pre-gash under the diaphragm, which looks very crescentic under the diaphragm. So this is a tricky question, but very important. I must appreciate the questioner that she took the point in mind that it is not known to the person. And what Sujat told, if it is both the side of the diaphragm, the diagnosis is very obvious. Moreover, there will be acute abdomen feature and all others. Altogether, I must say this was an excellent session. And also my question, like Sujat, almost except one, all the female students, they asked the question. So only one male student asked one question. We expect that all the students, they should have the same queries, same inquisitiveness, and they should comply. And also, it is a great opportunity that has been created by ACP Bangladesh chapter. I must say, all credit goes to Professor Nazmul Hassan, because thinking for the undergraduate student for their OSPE and calling people together, making all this is only possible when a teacher is really from the core of the heart asking for doing this throughout the Bangladesh. The students, they have joined, and I am sure everybody has been benefited like anything. And without doing class on the virtual platform, you have learned a lot. Just keep on, and really you will be doing very nice in your future. And those who are interested, they will come to medicine and they will do career in medicine in their postgraduate life, when they will be doctor, intern, and after that they will go for fellowship or MD, whatever they like. I'm sure that today's total session is a very successful one. And the whole team, I must congratulate, apart from Professor Nazmul, the whole team, those who are behind the screen, Dr. Prince, Dr. Jewel, that means Dr. Patwari, they have contributed a lot. And in future, obviously, we want to listen more and more on this OSPE, because this OSPE session will go for another few weeks, and we will be in touch with you, and some other liaison teacher will talk in front of you, and you tell your friends to join more and more so that you can learn and you can do better in your exam. Thank you very much. And with this, I must thank to the organizer to chair this session, and we will be waiting for a next week, next Thursday, to listen more things. Thank you very much, and I conclude and end of the session over here. Thank you very much.
Sadly, we have come to the end of today's program. We have learned so many important things about X-ray from sir today. It will definitely help to get the full marks on the X-ray part of OSPE or final MBBS examination. Many thanks to the speaker, the chair, the special guest, and last but not the least, the moderator sir for managing time from their very busy schedule. I'd like to thank all the audience who were with us throughout the event, especially those who asked very interesting questions. Hope you got your answer. If you joined late or couldn't see the whole program, there is no need to be worried. You will find the whole program on the YouTube right after the live session finishes. Our next masterclass on OSPE will held on 5th of March, where Professor Muhammad Alamin Midasar will discuss on pediatric OSPE. See you all in the next episode. Until then, take care. Good night.